but nobody's, not many have joined.
Yes, sir.
Eknath is there, eh? Saroj is joined. Eknath, did you ask about the acute rheumatic fever?
No, sir. I have Ronak, sir. I have asked.
Ronak, okay, Ronak, okay. Okay, we will start the discussion.
Yes,
Initially, we will discuss about acute rheumatic fever diagnosis.
yes, sir.
So, well, let me get an idea. What is your concept about acute rheumatic fever diagnosis? The modern criteria or the modified criteria? What is meant by relapse of the rheumatic fever? What is meant by recurrence of rheumatic fever? And how to diagnose recurrence of rheumatic fever? That is, we'll spend some time on the diagnostic criteria of the modified criteria and how to diagnose recurrence and relapse.
Yes, sir. Yes, sir.
Did you read about it? Do you have some? Would you like to give some comments about the diagnosis of acute rheumatic fever, the initial recurrence diagnosis, relapse diagnosis?
Sir, I have clear idea regarding acute rheumatic fever based on the modified Jones criteria.
Okay.
And recurrent.
You are talking about the modified Jones criteria of the WHO or that of the AHA?
Sir, that revised Jones criteria by based on the risk on the population, low risk population, high risk population.
Oh, that is AHA, the American Heart Association modification of the Jones criteria.
Yes, sir.
Okay, fine. That has come up in 2018.
Yes, sir. Yes.
Okay, right. Yes. What is it?
Yes, and regarding the basic that was confusion in that is that the progression of the disease, like stenosis of the valve occur is depend on the acute rheumatic fever or only separated from the based on the carditis, means recurrent carditis.
I could not follow your question.
That first episode of the acute rheumatic fever has occurred. Patient had carditis. That will progress to acute rheumatic. That will progress to valvular disease or recurrence of the carditis. That will progress to valvular disease.
Okay. See, for that, we have done a study on acute rheumatic fever about 90 patients.
Yes, sir.
And these patients were followed up for 10 years.
Yes, sir.
And what we found was that in about 50% of the patients, these are all patients who had acute mitral regurgitation as the valvular lesion.
Yes, sir. Yes, sir.
And we followed up these patients. They were on meticulously on penicillin prophylaxis.
Yes.
And these patients did not have any recurrence. And over a period of 10 years, what we found was that in 25% of the people, the valvular heart disease completely settled down.
Okay, sir. Okay.
There was no problem at all, even by echocardiography.
Yes, sir. Okay.
The normal disappeared. By echocardiographically, there was no evidence of any residual heart lesion. They completely recovered.
Recovered.
They had some caudal thickening, and there was some suggestion of mitral valve thickening, but there was no valve functional disturbance.
Okay, sir.
25% of people, there was no clinical evidence of valvular involvement, but on echocardiography examination, they had evidence of silent mitral regurgitation or subclinical mitral regurgitation.
Okay, sir.
In 50% of the patients, the valvular lesion decreased, but it persisted. The murmur could be heard, but echocardiographically, the severity of mitral regurgitation was much less. So what we concluded was, as is being reported in other literature also, the valvular damage is mostly very rare or very mild in the first episode of rheumatic fever, unless it occurs in a very young child. Below the age of 3, if there is acute rheumatic fever, there can be significant damage to the valves. But rheumatic fever occurring after the age of 5 or 6, usually in the initial episode, the valve involvement is there, but the damage is very little.
Okay.
And if you prevent recurrence of rheumatic fever, a good proportion of patients will completely recover, and in most of them there will be a decrease in the significance of mitral regurgitation. We also found that two patients, actually they gave a history of rheumatic fever, but when they were followed up, they had developed some degree of mitral stenosis.
Okay.
So two patients had mitral stenosis development, but that is independent of the valve recurrence or rheumatic fever. Recurrence rheumatic fever involvement usually gives rise to more and more mitral regurgitation or aortic regurgitation, and recurrent and progression to mitral stenosis is in very small percentage. And to our surprise, we have also found that of all the patients who came to our clinic with mitral stenosis, who did not give any past pure mitral stenosis, who did not give any past history of rheumatic fever at all. So whether there was a study from Vellore, whether they have even questioned whether pure mitral stenosis, is it all due to rheumatic fever, or is it due to viral infection or something else also being raised. But at the moment, according to the WHO criteria everywhere, if there is a rheumatic, if there is a mitral stenosis, it is of rheumatic etiology. Okay, that's one point. So what is the criteria? Can you elaborate the AHA criteria of 2018?
Sir, it's based on the low risk population and high risk population.
How do you differentiate low risk from high risk?
Sir, in low risk population, the rheumatic fever incidence is less than 2 per 1 lakh, less than 2 per 1 lakh school going age, and 1 per 1 or less 1,000 population of the per year. That is for the low risk population.
So the low risk population is less than 2 per lakh of school going students.
Yes.
Or 1 per 1,000 in the population.
One in the population.
Okay, right. Yes, very good.
Yes.
The criteria?
Sir, criteria, there are two. They have divided into major criteria and the minor criteria.
Okay.
For high risk population, the major criteria would be carditis, arthritis, that is a polyarthritis, the chorea, subcutaneous nodule, and erythema marginatum. In minor criteria would be even monoarthralgia can be considered it as a minor criteria in high risk population. Along with that, a fever of 38 Celsius, that is considered, and ESR of more than 30 and CRP more than 3, prolonged PR interval. So this would be the minor criteria. So if
no, you will explain to me what is the main difference between low risk population and high risk population as far as the criteria are concerned.
Sir, low risk population is it is a epidemic area where the incidence.
No, that's right. No, criteria that you have already defined, that 2 per 100,000 school going children, or less than 1 per 1,000 population. That's fine. I am asking you now, what is the difference in criteria put forward by American Heart Association between the low risk population and high risk population?
Sir, the main difference in major criteria, they have concluded that it is in arthritis, it is polyarthritis considered it as a major criteria, and in a minor criteria, there would be fever has to be more than 38.5 Celsius. The ESR has to be more than 60. And these two differentiating features in minor criteria that has to be differentiated from the major criteria.
What do you mean this criteria? Is it for a low risk population or a high risk population?
Sorry, sir.
This criteria that you said, that a temperature more than 38.4,
It's a low risk population, sir.
Low risk population.
Yes.
What is the criteria for high risk population?
For high risk population, temperature has to be 38 is considered as a minor criteria, 38 on Celsius. Yes. And another point is CRP has to be 30. More than 30 it is considered, and CRP is more than 3 and ESR more than 30. That is considered it as a in major in high risk population, it is considered it as a minor criteria.
Any difference in the joint involvement?
Sir, in joint involvement, even monoarthritis in high risk population is considered as a major criteria.
Okay.
Single joint involvement.
And also they have included even polyarthralgia.
Arthralgia.
Also in the major criteria in a patient in the high risk population.
High risk population.
Okay. So, and what is the difference between relapse and recurrence?
Relapse of the fever even after the first episode, patient had again features of acute rheumatic fever that fulfill the major criteria and the minor criteria. It like two major or one major criteria or three minor criteria. So that is considered it as a relapse of the acute rheumatic fever.
No, that's not correct. Relapse, actually, relapse and recurrence difference is depending upon the. Anybody who knows what is the difference between relapse and recurrence of rheumatic fever? Anybody? Shashank Tiwari, would you like to try? Saroj, what is the difference between relapse of rheumatic fever and recurrence of rheumatic fever?
Sir, it depends whether patient is on treatment or not.
Yeah, the patient is a patient had acute rheumatic fever. He had a full course of treatment. Then what is
yes, sir. In case of sir relapse, the patient is symptom. Patient is after the full treatment of the rheumatic fever. The sir, there is a sir. No, sir. Sir.
Anybody who would like to try to answer that question? What is the difference between relapse of rheumatic fever and recurrence of rheumatic fever? Relapse, as you know, it means that the same disease after treatment has relapsed. You can get typhoid relapse. Typhoid can relapse sometimes, many times. Nowadays, it is not there because there is an effective eradicating treatment. But previously, typhoid is a disease which used to relapse 2 or 3 times. Recurrence means the patient may get a repeat infection. Similarly, in rheumatic fever, what is meant by relapse and recurrence?
In case of recurrence, sir, fever in rheumatic fever, which is fully recovered, and sir, there will be a same episode. It will respond to the same treatment, sir.
What do you mean by same episode? What do you mean by same?
The patient has fully recovered.
No, I think you don't know. Don't try now. Anybody who would like to try? So, yeah, yes.
Recurrence is patient with rheumatic fever treated, and he was asymptomatic for 8 weeks, and again he starts a new episode. And relapse patient with infection was on treatment, but on tapering the treatment, patient started having symptoms again.
Okay, you're almost right. And not tapering the treatment, stoppage of treatment.
Okay, sir.
8 months is all right, 8 weeks is all right, but it is usually written as 2 months. If the relapse is after cessation of treatment, completion of treatment, within 2 months of time, the patient comes back with rheumatic fever symptoms. That is known as relapse. If the patient comes back after 2 months of the cessation of treatment, then it is known as recurrence. Is it clear? So the time gap is the most important thing. After cessation of treatment, the treatment is completed, the patient had good remission of symptoms, patient improved, and then you stop the medication, and within 2 months the patient comes back with symptoms, then that is known as relapse. If the patient comes back with symptoms a period after 2 months, 3 months, 4 months, 5 months, then it is classified under recurrence of rheumatic fever. What is the difference in criteria for the diagnosis of recurrence and initial episode? Ronak?
Sir, for recurrence of the rheumatic fever can be diagnosed with two major or one major plus two minor criteria.
And also?
Also three minor criteria.
Three minor criteria. Actually, AHA has said that even in presence of three minor criteria, you can diagnose relapse of rheumatic fever. And there are a few conditions, situations where the rheumatic fever recurrence can be diagnosed, or rheumatic fever can be diagnosed without any evidence, any other evidence, like the pre-existing or preceding streptococcal infections, beta hemolytic streptococcal infection evidence, or even in the absence of minor criteria. Presence of major criteria alone is enough to diagnose rheumatic fever. What are those conditions, situations? Any one of you? Saroj, would you like to try? Okay. When the patient with presence with chorea, rheumatic chorea, no other criteria are required. Even preceding streptococcal infection, evidence of preceding streptococcal infection is not required. Any child presenting with chorea is diagnosed to have acute rheumatic fever because of a single criteria is enough. Why is it that chorea we are not looking for other criteria? Ronak?
Because the chorea is late manifestation. By the time the acute phase reactant as well as the acute rheumatic fever criteria will not be present, because it usually come after 3 months.
Very good, excellent. That is the reason. The rheumatic chorea occurs around about 3 months after the episode of streptococcal sore throat or streptococcal infection. And if you test that patient after 3 months when the rheumatic chorea has occurred, you may not get evidence for preceding preceding streptococcal infection as evidenced by culture or antigen or antibodies, because it is already 3 months late. And so that criteria is excluded. And most of the major criteria of rheumatic fever, like arthritis or arthralgias or carditis or subcutaneous nodules or erythema marginatum, all these things occur about 7 to 14 days after the streptococcal infection. So by the end of 3 months, all these major criteria, if it was there at all, they might have completely settled down. So for diagnosis of acute rheumatic fever, in presence of chorea, there is no other evidence is required. Okay, what is other criteria? What is the other situation where you need not look for other major criteria, other criteria? It is described that if the patient is having continuing carditis, as evidenced by patient's cardiac condition deteriorating, the character of the murmur changing, if such a situation is there, it is also stipulated by WHO that you need not look for other evidences, because that criteria, that alone indicates that the patient is having continuing rheumatic activity. So these are the two criteria where situations where you don't look for other supporting evidence or other minor criteria before you make the diagnosis of acute rheumatic fever. Okay, so I will just go through it, then we'll have discussion once more. Siddhi, can I share my screen? Okay. Okay, right, fine, thank you. Okay, acute rheumatic fever, I will start from the beginning. Acute rheumatic fever diagnostic criteria, modified Jones criteria by American Heart Association, 1992. The criteria were carditis, arthritis, chorea, erythema marginatum, subcutaneous nodules. And these are the major criteria. Minor criteria, hyperpyrexia, fever more than 38 degrees centigrade, arthralgia without other signs of inflammation, laboratory indicators of acute phase reactants like ESR, CRP elevation, prolonged PR interval in electrocardiogram in the absence of carditis as a major criteria. So these are the minor, you should always mention that if the patient is already diagnosed to have carditis as a major criteria, then PR prolongation in the electrocardiogram cannot be taken as a minor criteria. So minor criteria, PR prolongation is taken when the patient is only having arthritis as a major criteria, and then you find that other supporting evidence of fever, and if the patient is having prolonged PR interval, then that is an additional criteria to diagnose rheumatic fever. What is the reason for the prolongation of the PR interval in rheumatic fever? Any one of you? What is the reason? Is it because of the inflammatory process of the acute rheumatic fever affecting the conduction system or something else? It is thought that the PR prolongation mostly is related to the vagal activity and not due to any direct inflammation of the conduction system. There is no evidence that the conduction system can get involved in the inflammatory process of acute rheumatic fever. So the diagnostic criteria for acute rheumatic fever 1992 was these are the major criteria, minor criteria, and evidence of antecedent streptococcal infection, throat swab culture or rapid antigen test positive, elevated or steadily increasing anti-streptolysin antibodies titer in the serum. If the ASO titer is negative, then what is the other antibody that you usually test?
High.
What is the next antibody that you can test?
Anti-deoxyribonucleodase,
Yeah, anti-DNase.
anti-DNA.
Anti-DNase is the next. What is the percentage of patients where the streptolysin O titer, the streptolysin O may be negative, and then you can get anti-DNase positive?
Sir, around 80%, 70 to 80.
80 to 90% you can get. In 10 to 20% of cases, you may get anti-DNase as the antibody diagnosis of for the diagnosis of streptococcal infection. Streptolysin O titer may be elevated in 80 to 90% of patients in children with acute rheumatic fever, but about 10 to 20% it may not be elevated. And what do you mean by increasing titer? What do you mean by increasing anti-streptococcal antibody titer? What is the criteria? Any one of you? If it is doubling in 2 weeks' time, then that is suggestive of increasing streptococcal antibody titer. So in 2 weeks, if you have got a doubt, you would do the anti-streptolysin O titer. 2 weeks later, you repeat it. If it has doubled, then you are sure that there is a streptococcal infection and there is a progressive increase in the antibodies against the streptococcus. And as pointed out by Ronak, the criteria for the diagnosis of acute rheumatic fever is in the sense of a antecedent streptococcal infection, one major criteria, or two minor criteria, or two major criteria. That is enough. And now coming to the okay, this is the criteria put forward by American Heart Association in 2015. It was modified in 2015, not in 18. Sorry, 2015. And the criteria already Ronak has mentioned about it. They divided the population into a low risk population and a high risk population. And what is a low risk population?
low risk population less than 2 per 1 lakh school going children.
A low risk population is one in which cases of acute rheumatic fever occur in less than 2 per 100,000 school age children. Or rheumatic heart disease is diagnosed in less than 1 per 1,000 patients at any age during 1 year in the population. So there are two criteria to be satisfied before you categorize a society as a low risk population. 2 per 100,000 school age children. The recurrent acute rheumatic fever cases should be less than 2 per 100,000 school age children, or rheumatic heart disease in the general population of less than 1 per 1,000. Let's look at the criteria put forward by American Heart Association. Major criteria: carditis, clinical or subclinical. Ronak, what is meant by subclinical?
Subclinical.
Clinical or subclinical?
Patient may have carditis, but we can't get it on the clinical examination. But on the echocardiography, we can find the features of carditis like mitral regurgitation and
aortic regurgitation.
Aortic regurgitation.
You're right. So patients in whom on clinical examination you are able to detect the murmur, that is a clinical carditis. But if you are not able to clinically detect the murmur, but on echocardiographic examination you have got evidence of mitral or aortic valve regurgitation, then that is a subclinical carditis. Okay, so clinical or subclinical carditis, low risk population. Arthritis, only polyarthritis. That's the most important point. Arthritis, they consider only polyarthritis as the diagnostic criteria for acute rheumatic fever in the low risk population. Chorea, erythema marginatum, and subcutaneous nodules. So the main difference here is that the subclinical carditis also is included as a major criteria. In the high risk population, things are slightly different. Carditis, clinical or subclinical, that's the same. Arthritis, it includes even monoarthritis. In the low risk population, it was only polyarthritis. Here it is monoarthritis or polyarthritis, both are included. And also polyarthralgia also is as a high risk population, in the high risk population, especially migratory polyarthralgia. Chorea, erythema marginatum, and subcutaneous nodules remain the same. Now, in the minor criteria, in the low risk population, polyarthralgia, hyperpyrexia, 38.5 degrees centigrade, ESR more than 60 millimeters per hour in the first hour, and or CRP more equal to or more than 3 milligrams per deciliter. Prolonged PR interval after taking into account the difference related to age if there is no carditis as a major criteria. That's the most important point. If you already included carditis as a major criteria, then PR prolongation cannot be included as a minor criteria. High risk population, monoarthralgia. Polyarthralgia goes in the high risk population, polyarthralgia, especially migratory, goes as a major criteria. But in the high risk population, monoarthralgia is a minor criteria. Hyperpyrexia, more than 38 degrees centigrade is enough. ESR more than 30 millimeters in first hour is enough. And CRP the same. Prolonged PR interval also the same. So the major difference is in the joint manifestations, as evidenced by even monoarthritis and polyarthralgia are considered as major criteria in the high risk population, while in the low risk population it has to be polyarthritis. Then subclinical carditis has been brought into the diagnostic criteria of acute rheumatic fever, both in the high risk population as well as in the low risk population. First episode, the diagnosis of acute rheumatic fever can be made in presence of two major criteria or one major and two minor criteria with evidence of antecedent group A beta hemolytic streptococcal infection that all of you know. When it comes to recurrence, there is a minor difference. AHA has recommended that diagnosis of subsequent episodes of rheumatic fever requires two major criteria as in the initial episode, one major and two minor as in the initial episode, or three minor criteria. You also put that if the patient is having 3 minor criteria like fever, prolonged PR interval, and CRP elevated, then that is enough to diagnose rheumatic fever. That's a very, very, very loose criteria, and you have to be careful that you are not missing some other diagnosis. So, according to the rheumatic fever recurrences, what is meant by rheumatic fever recurrence? According to AHA criteria, with a reliable past history of acute rheumatic fever or established rheumatic heart disease, and in the face of documented group A streptococcal infection, 2 major or 1 major and 2 minor or 3 minor manifestations may be sufficient for a presumptive diagnosis of recurrence of rheumatic fever. 2. When minor manifestations alone are present, the exclusion of other more likely causes of the clinical presentation is recommended before a diagnosis of an acute rheumatic fever recurrence is made. In a patient with a pre-existing or a past history of rheumatic fever, there is a very likelihood that he may get a recurrence of acute rheumatic fever. So there is every likelihood that the patient may be having the recurrence, but if you are depending only on minor criteria, other situations where like minor infection by any other organism sometimes can give rise to fever, arthralgia, and raised ESR. So sometimes minor criteria, the making use of 3 minor criteria for the diagnosis of acute rheumatic fever should be very cautiously done. Then what is the echocardiographic criteria of acute rheumatic fever? The echocardiographic criteria can be classified into two categories. One is the Doppler criteria and other is echocardiographic or structural criteria. What is the echocardiographic Doppler criteria? Pathological mitral regurgitation. There are 4 criteria to be satisfied before you can diagnose pathological mitral regurgitation due to acute rheumatic fever. They are: 1, the mitral regurgitation should be detected in at least 2 projections, the apical 4 chamber view or and also in the parasternal long axis view. Regurgitation jet length at least should be at least 2 centimeters at least in one projection at least in one projection. The regurgitation jet should extend more than 2 centimeters into the left atrium. Regurgitation peak velocity should be more than 3 meters per second, and the regurgitation should be pansystolic. So American Heart Association has put forward 4 criteria, echocardiographic criteria, where all 4 should be diagnosed before you diagnose mitral regurgitation due to acute rheumatic fever. The pathological aortic regurgitation, again 4 criteria, all must be met visible at least in 2 projections. Regurgitation jet more than 1 centimeter at least in one projection into the left ventricle. Regurgitation peak velocity more than 3 meters per second, and regurgitation is pan-diastolic. So all these 4 criteria should be satisfied both for mitral regurgitation as well as mitral aortic regurgitation in order to diagnose echocardiographic diagnosis of rheumatic fever as a major criteria. And if the murmur is not audible on clinical examination, then these criteria are satisfied. Then you call it a subclinical carditis. Then what is the echocardiographic morphological criteria? In acute mitral valve involvement, the morphological criteria are dilatation of the mitral annulus, elongation of the chordae tendineae, rupture of chordae tendineae with acute mitral regurgitation, prolapse of anterior or sometimes rarely posterior leaflet. Anterior leaflet prolapse is much more frequent, and almost always it is the anterior mitral leaflet which is prolapsing. Unlike in the classical mitral valve prolapse where the posterior mitral leaflet prolapses, especially in Marfan syndrome or situations where there is a papillary and LV size discordance. Sometimes patients can have mitral valve prolapse, and the prolapsing cusp is the posterior mitral leaflet. While in the mitral valve prolapse seen in patients with acute rheumatic fever, it is the anterior cusp which is prolapsing. Sometimes you may be able to see few nodular lesions on the leaflets. In chronic mitral valve involvement, that is where the patient has had an acute rheumatic fever, and the involvement of the valve has resulted in chronic structural changes, which include thickening of leaflets, thickening of chordae tendineae with fusion, limited mobility of leaflets, and calcifications. So these are the four criteria for the established rheumatic fever involving the mitral valve. When lesions in acute and chronic aortic valve involvement, what is the structural abnormality that you can detect on echocardiography examination in a patient with acute rheumatic fever? Symmetrical or focal thickening of leaflets, disturbed leaflet coaptation, the leaflet coaptation does not take place correctly, limited mobility of the leaflets, and sometimes even prolapse of the leaflets. All these things can happen as evidence of something like a more of a chronic aortic valve involvement in a patient with acute rheumatic fever. So when you look at the echocardiographic criteria for the diagnosis of acute rheumatic fever, there are two sets of criteria. One is Doppler dependent, and second is structural abnormality, which is mostly detected by echocardiographic examination, from the ultrasound examination. When it comes to WHO criteria, there's a bit of a confusion. WHO has brought out the criteria, latest is 2002-2003, and after that our knowledge about acute rheumatic fever has significantly gone up, especially with the availability of echocardiographic examination to detect clinical as well as subclinical carditis in patients with acute rheumatic fever. So how to diagnose primary episode of rheumatic fever? Two major or one major and two minor criteria manifestations plus evidence of preceding group A streptococcal infection as usual. Recurrent attack of rheumatic fever in a patient without established rheumatic heart disease. When will you diagnose that there is a recurrence of acute rheumatic fever in a patient who did not have any evidence of acute carditis? Two major or one minor and two minor manifestations, one major and two minor manifestations plus evidence of preceding group A streptococcal infection as usual. A recurrent attack of rheumatic fever in a patient with established rheumatic heart disease. That becomes more difficult because if the patient is having established rheumatic heart disease with mitral regurgitation, recurrence of valvulitis may become extremely difficult as a clinical diagnosis. So what are the criteria? They have said that two minor manifestations plus evidence of a preceding group A streptococcal infection is enough. You need not always think of major criteria, but even two minor criteria manifestations like fever and arthralgia or monoarthralgia or fever with raised ESR in a patient who has got an established rheumatic fever, rheumatic heart disease may be enough to diagnose the recurrence of rheumatic fever. Rheumatic chorea, insidious onset of rheumatic carditis. These are the two criteria where other major manifestations or evidence of group A streptococcal infection not required. That's the most important thing you should remember, that in patients with presenting with rheumatic chorea, it is always rheumatic. There is no need to look for other, if it is there, yes. But if it is not there, still the diagnosis is acute rheumatic fever, rheumatic chorea. And insidious onset rheumatic carditis, here usually the patient starts with rheumatic carditis and it progressively persists, and the patient's valvular lesion may increase in intensity and new valvular lesions may appear. That is known as insidious onset rheumatic carditis. And patients with chronic valve lesions of rheumatic heart disease presenting for the first time with pure mitral stenosis or mixed mitral valve disease and or aortic valve disease, they are considered, they do not require any other criteria to be diagnosed having rheumatic heart disease. That's the most important point. Even if the patient does not give any past history of rheumatic fever, in a patient with multivalvular disease or a patient with mitral stenosis, etiology is most likely rheumatic. Now, major criteria, minor criteria, manifestations are the same. There is no difference. Carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules. While minor criteria include clinical fever, they are not mentioned about hyperpyrexia, or they are not set aside 38 degrees centigrade or 38.5 degrees centigrade, but they said that fever. Polyarthralgia. Polyarthralgia here comes under a minor criteria, while polyarthralgia in a high-risk population is considered as a major criteria according to American Heart Association. Laboratory evidence of elevated acute phase reactants like erythrocyte sedimentation rate as well as leukocyte count. An electrocardiogram showing prolonged PR interval in the absence of carditis as a major criteria. Supporting evidence of preceding streptococcal infection within the last 45 days. That includes elevated or rising anti-streptolizin O or other streptococcal antibodies, or a positive throat culture, or rapid antigen test for group A streptococcal infection, or a recent scarlet fever. American Heart Association has excluded scarlet fever, but WHO in its criteria of 2002-2003 still mentions about scarlet fever. Nowadays, people don't consider scarlet fever as evidence of a preceding streptococcal infection, even though it is still included in the WHO criteria. So you can both the criteria you should know. When it comes to WHO, there is a minor difference, but AHA criteria, which is which is the latest criteria, has specifically said about the criteria for society with high risk society, low risk society, and also included subclinical carditis as evidence of a major criteria. Patients may present with polyarthritis or with only polyarthralgia or monoarthritis. This is a WHO recommendation, and with several 3 or more other minor manifestations, together with evidence of recent group A streptococcal infection. So patient can have evidence of a recent streptococcal infection. They can have minor criteria like arthralgia, or they may have fever, high ESR. So 3 or 4 criteria may be satisfied. So there is every possibility that you are dealing with a case of acute rheumatic fever. Then what should be the approach? Some of these cases may later turn out to be rheumatic fever. It is prudent to consider them as cases of probable rheumatic fever once other diagnoses are excluded, and advise a regular secondary prophylaxis. That is the recommendation of WHO. Such patients require close follow-up and a regular examination of the heart. This cautious approach is particularly suitable for patients in vulnerable age groups in high risk population, especially population with very high incidence of rheumatic fever, acute rheumatic fever, and in the high risk population, that is 5 to 15 years of age. If you get 3 or 4 minor criteria, the WHO recommends that the patient may be started on penicillin prophylaxis, secondary prophylaxis for a period of, they recommend for a period of a year, and reassess. And if there is no more evidence of rheumatic fever, probably the secondary prophylaxis may not be continued. Then, of course, in these patients, other diagnosis should be considered and ruled out, like infective endocarditis, and some patients with the recurrent attacks may not fulfill this criteria. So, because without fulfilling these criteria, some of the patients can even have recurrence, especially insidious onset carditis. And always, when a patient is coming with in a very young patient of 2 or 3 years of age, before you diagnose acute rheumatic fever, you should always consider whether it could be a congenital heart disease. So that also should be thought of, especially in a very in a patient who is less than 3 years of age, coming with mitral regurgitation, where you are suspecting that it could be a rheumatic carditis. Usually, rheumatic carditis occurs after the age of 5. Between 3 and 5, rarely, occasionally it can happen, and below the age of 3, it is extremely rare. And also, one more thing you should remember, that as the age becomes less and less, the rheumatic involvement affects the heart more frequently. And as the age becomes more and more, the involvement of the heart becomes less and less, and joint involvement becomes more prominent. So in a patient who is 12, 13, 14, 15, when the rheumatic fever occurs, there's every possibility that joint involvement may be more striking and then carditis. While if it occurs in a patient who is 4 years to 4 years, 5 years, then the cardiac involvement will be much more severe and much more prominent. Okay, there is something about acute rheumatic fever, and as I told you, the difference between relapse and recurrence is if the patient after completion of the treatment, if there is a reappearance of the rheumatic fever symptoms within 2 months, it is considered as a relapse, and after 3 or 2 months, it is considered as recurrence. Okay, any doubt about Ronak? Are you clear?
Yes, sir. Yes, sir. Yes, sir.
Others, if you got any doubt, you should ask now. Saroj, is it clear to you?
Yes, sir. Yes, sir. Yes.
So I think that's about the different criteria for the diagnosis of acute rheumatic fever, initial episode, and then what is meant by relapse, what is meant by recurrence, and what are the different criteria put forward by AHA and WHO. WHO criteria is a bit old, so I would recommend that you may rely more on the AHA criteria. Okay, now I thought we will discuss something about intracardiac masses. I think echocardiographic diagnosis of intracardiac masses. So slightly different from what we are regularly doing. Okay, let us look at intracardiac masses, echocardiographic assessment. And what are the intracardiac masses that you come across when you do an echocardiographic examination? Saroj? Ronak, anybody? What are the intracardiac masses that you come across and look for?
Sir, intracardiac mass,
Oh.
thrombus.
What are the intracardiac masses that you look for when you're doing a regular echocardiographic examination?
Sir, we can look for thrombus,
Thrombus, very good.
tumor,
Tumor, very good.
vegetations.
Vegetations, yes.
Sometimes, sir, some ruptured cordy.
Yeah, very good. Some of the normal structures may mimic a intracardiac mass, very good. Like, can you mention few examples?
Like, sir, ruptured cordy.
Record, yes. These normal structures which are mimicking a mass is more frequent in atria than in the ventricles.
Yes, sir. Like, sir, sometimes in the right atrium, we get some spiral filament-like structure. Sir, I have forgotten the exact name.
Okay.
In RA, we get.
What are the structures that we can get which will sometimes confuse with intracardiac mass?
Eustachian valve in IVC.
Very good. I Eustachian valve. Chiari malformations.
Yes, sir. Cherry.
Then what else?
Sir, sometimes at the ASD level, we can get aneurysmal.
Yes, aneurysms. Sometimes aneurysm may, unless you are very careful, you may misinterpret it.
Sometimes, sir, sinus of Valsalva, not ruptured, but confusion with the mass.
Okay, sometimes the sinus of Valsalva, unruptured sinus of Valsalva may sometimes project into the atrial chambers and may confuse you. Very good, yes. And sometimes the crista terminalis is something in the right atrium which may sometimes mimic a tumor mass. And sometimes if you are not aware of that, sometimes you may wrongly interpret it. So there are, when you look for the intracardiac masses, mostly it is tumor, thrombus, and vegetations. And then you look for structures which can mimic a tumor or a mass, which may be normally present. Let's look at few things. So intracardiac masses include tumor, thrombus, vegetation, and granuloma. We forgot about granuloma. Tuberculosis sometimes can give rise to granulomas, and it could be seen on the. Sometimes it can be seen on the in the leaflets, or sometimes in the projecting into the cavity. Sometimes granulomas can be seen. Prosthetic material like prosthetic valve or any prosthetic material can be. Sometimes you keep. Sometimes leadless pacemakers are there, where now you can put the battery, everything in the right ventricle. So prosthetic material is something which can be seen as a intracardiac mass. Non-cardiac, normal cardiac structures mimicking a mass, we have already mentioned, and ultrasound artifact. Sometimes there can be ultrasound artifact, and which may make you suspect that it could be a tumor mass, especially in the calcification. Sometimes give rise to ultrasound artifacts, and that sometimes confuse you with a tumor mass. Now, a few things about in the tumors. Primary tumors of the heart is much less frequent than secondary tumors. Almost 80 to 90% of tumors of the heart is secondary, and only about 10 to 20% are primary. And the primary tumors are myxoma is the commonest. It's a commonest primary tumor. Other primary tumors include lipoma, papillary fibroelastoma, hemangioma, rhabdomyoma, mesothelioma, or Devi node. How will you differentiate all these things? Any one of you? How will you differentiate myxoma, and how will you differentiate papillary fibroelastoma? Any one of you? Would you like to make a comment? What are the diagnostic criteria for myxoma, and which is the chamber where you get the largest number of myxomas? Okay, we'll go to criteria. Commonest, you already know, it is left atrium is the commonest chamber where you can get myxoma. So left atrial myxoma is the commonest one which we come across, and this is the commonest cardiac tumor also. What are the other cardiac chambers in the order of occurrence? The myxomas occur. Any one of you? Following left atrium, which is other cardiac chamber where you can get a myxoma?
Right atrium.
Right atrium, very good, excellent. Followed by?
The right ventricle.
No.
No.
So that's only another chamber is left ventricle. So left atrium, right atrium, then left ventricle, right ventricle. The same order. Left atrium, right atrium, left ventricle, right ventricle. The right ventricle is the chamber where there is the lowest incidence of myxoma. So whenever you get a tumor in a ventricle, right ventricle, don't jump and say it's a myxoma unless it has got the classical features. You always think of the fibroma is much more frequent in right ventricle compared to myxoma. And also one important thing about the right ventricle is that right ventricular outflow masses, outflow tumors are usually malignant. They are much more likely to be malignant than benign. So whenever you find a tumor in the RV outflow region, you should be very careful in labeling it as benign, and they should be quickly investigated and surgical removal should be carried out, because the majority of tumors in the RV outflow are malignant rather than benign. So what are the diagnostic criteria of myxoma? How will you diagnose myxoma? Left atrial myxoma, how will you diagnose? Any one of you criteria for the diagnosis of left atrial myxoma? When you think of a tumor, first thing that you should think is whether it is sessile or pedunculated. So left atrial myxoma, is it sessile tumor or a pedunculated tumor?
Peduncular tumor.
It's a pedunculated tumor. Second point is that anybody would like to make a comment about the features of left atrial myxoma by echocardiography.
It's a more dense, sir.
Eh?
It's a more dense.
I couldn't follow you. What did you say? It's more?
It's a more dense.
More dense.
Oh.
No. Rather than that, you can say that the density varies in different regions. In some regions it is calcified, so it is very dense. Some regions not calcified. Some regions it may be even liquefied. So the density of the intracardiac, the density of the mass varies in regions. That criteria is very often is fragmented. So it is not a uniformly round mass. It is usually very often it is fragmented, and it has got a tendency to embolize also. So fragmented. Three important criteria for the diagnosis of myxomas are: one, fragmented; two, it is a pedunculated tumor; and third is that you can see the areas of calcification mixed with liquefaction, and normal density masses are seen. So let's look at one. So here you can see, if you are very careful, you can see the calcification here. Then you can see areas which are more rarefied. And you can see here the more rarefied area, very clearly seen. And you can see in between tissues with a normal density. And you can, if you are very careful, you can think probably this pedicle is not very well seen, but you can think that probably it is attached somewhere here. And it is fragmental. So you can see that there are some projections from the myxoma. Here also you can see some projections. And that is why there is always a risk that the left atrial myxoma can embolize and may result in a stroke. So the three criteria for the diagnosis of myxomas are: one, it is a pedungulated tumor; two, there are areas of calcification mixed with liquefaction; and three, it is a fragmented tumor with a friable tumor, and you can see projections from the surface of the tumor. So another example of a left atrial myxoma, you can see calcified region. Some of the regions are less echodense. It is attached to the intracardiac septum, and very often it is thought to be that it is a classical site where it is attached is onto the in and around the fossa ovalis on the left atrial side, on the interventricular septum near the fossa ovalis on the left atrial side. Sometimes it may be very difficult to see from the transthoracic view, especially in a very obese person. You can see something which is moving here, but actually it is much less clearly seen than what we saw previously, because that was in a very thin chest wall person. Here it is a very thick wall person, thick chest wall person, elderly person, and then a transesophageal echo always helps. Whenever you want to look at something which is in the left atrium and you want more clarity, then transesophageal echo is always useful, because transesophageal echo looks from behind, and left atrium is a posterior structure, and two, it is close to the left atrium, so the left atrial structures, the tumors, masses, whatever it is, becomes much more clear. And so whenever you are suspecting in the left atrium, and if you want more clarity, then you should depend upon transesophageal echo. And here in this patient, when the transesophageal echo is done, you can find this large mass, very huge mass, and it is projecting into the mitral valve during diastole. Actually, one of the conditions diagnosed by the person who initially used the ultrasound for the diagnosis of cardiac conditions is left atrial myxoma. And he diagnosed it by looking at the M mode, where you can see that the shadow of the left atrial myxoma is seen in the left atrium during systole. In diastole, it falls into the, this is the, in the diastolic phase, it falls into the, this is the systolic phase, this is the diastolic phase, and during the diastolic phase, it falls into the mitral valve, and then it is moved away from the M mode echocardiogram. So when even if you are periodically seeing a shadow coming in and out of the in the left atrium in an M mode examination, then that may be a criteria for the diagnosis of left atrial myxoma. So here, this shadow that you are seeing here, the shadow that you are seeing here, this shadow, this shadow, this shadow, this shadow, all are due to left atrial myxoma projecting into the left atrium during systole and is being picked up by the M mode examination. So this is the M mode examination of the same patient which I showed you in the M mode slide. You can see that this is the left atrial myxoma. Here you can see the friability of the left atrial myxoma is very clearly seen. It's quite friable. Then you can see that it is attached to the intracardiac septum. And you can also see certain areas of calcification where the density is going on changing. Some areas are liquefied and some areas are more dense, some areas are calcified, So a change in the morphology as well as the echogenicity of the tumor mass is a point in favor of myxoma. And of course, whenever there's a tumor in the left atrium, you must always think of left atrial myxoma. Rarely it can be seen in the mitral leaflet also. Very rare, it's a rare one. Here, actually, the fibril masses are much less, but you can see areas of liquefaction, and this was surgically removed and was confirmed as a case of myxoma. Right atrial myxoma, though rare compared to left atrial myxoma, but right atrium is the next chamber where there can be a myxoma. So you can see the myxomatous mass here. You can see that the mass is here. And this was surgically removed and was found to be a left atrial myxoma, a right atrial myxoma. So myxoma is the commonest primary cardiac tumor. Common site is left atrium. Most often it is single, but in 5% of cases it can be multiple. It has got an irregular shape. I said it's friable. It is also known as grape cluster. It is non-homogeneous. Areas of calcification, areas of liquefaction. It's a pedungulated tumor and is freely mobile. So these are the features of myxoma, especially left atrial myxoma, which is attached actually to the in and around the region of the fossa ovalis on the left atrial side. And this tumor, in 5% of cases, it can be multiple, or rather, it can be in different chambers also. So 5% it can be multiple or in different chambers. It has got an irregular shape, friable tumor mass, and it can get dislodged and go to the systemic circulation. And this is the shape of the tumor is classically described as grape cluster. Can anybody tell me how will you diagnose papillary fibrillostoma? What it is? What is it? And what is the most important differential diagnosis of papillary fibrillostoma? Any one of you? Ronak, would you like to try?
Sir, it is present is in the LV chamber, a cord-like structure, more and more. It is more dense than the surrounding structure.
What is the relevance of papillary fibrillostoma, and what is the important complication of papillary fibrillostoma?
Maybe patient may have Marfan syndrome.
No, not Marfan syndrome. Any one of you would like to comment about papillary fibrillostoma, what it is? It's a small tumor actually. It's not a large one, small one. Mostly occurs in relation to the valves. And because it occurs in relation to valves, very often it has to be differentiated from infective endocarditis vegetation. It may simulate an infective endocarditis vegetation. But the most important differentiating point is that infective endocarditis vegetations are mostly seen in the upstream side of the valve. For example, in the vegetations of the mitral valve are seen on the left atrial side, and vegetations of the aortic valve are seen on the left ventricular side. While it is just the opposite in papillary fibrillostoma. It is seen on the downstream side of the valve. So when it is seen in relation to the mitral valve, it is usually seen on the left ventricular side, and so the same thing is true for aortic valve also, where it is seen on the aortic side. So papillary fibrillostomas are small tumors. They are very small. They simulate infective endocarditis vegetation, the most important point. And also the main differentiating point is that the papillary fibrillostoma occurs on the downstream side of the valve as against the infective endocarditis, which occurs on the upstream side of the valve. The most important problem with the papillary fibrillostoma is that thrombi or the platelets can get adhered to the surface of the papillary fibrillostoma. It can stimulate it can cause activation of the platelets. It can get aggregated and thrombus may be formed and it may get dislodged. So patients with papillary fibrillostoma, that's what the developing embolic episodes. It need not happen, or not a very common thing, but it can happen. And so many people recommend that when you find a papillary fibrillostoma, it is better to remove it so that the patient is very safe. But then you should remember that most of the times, especially if there is a papillary fibrillostoma in relation to mitral valve on the ventricular side, then the surgical removal may be more difficult. But if there's a papillary fibrillostoma in a very more approachable region, then surgical removal may be beneficial so that we can prevent the occurrence of a stroke. I show you 3 examples. If you are very careful, you can see something here. Okay, something is seen here. You can see something is seen here, and you can see also something here. These 3 views of are that of a patient with papillary fibrillostoma. This is another example of papillary fibrillostoma. It is seen on the ventricular side of the aortic valve. Sorry, aortic side of the aortic valve. You can see a small one here, very close to the aortic valve. You can see it here. It has got a pedicle. It is attached to the aortic valve. You can see it here. Patient came with symptoms of some joint symptoms and some uneasiness, and this is what Echo showed these findings. And a diagnosis of it was further investigated, including a cardiac MRI. And fibrillostoma was made. So this is a situation where sometimes you may be in a dilemma. What is the correct approach to the problem? Because the embolic episodes are not that frequent, and to suggest an open heart procedure for a small lesion, which may or may not, or sometimes you have got a doubt that it may give rise to an embolic episode, then it may be worthwhile to remove the tumor. If the patient had already one episode, then of course there is no doubt that this has to be surgically removed. Surgical removal is the treatment of choice, especially in a patient who has got some evidence of embolic episode. But if the patient did not have any embolic episodes, everything is fine, probably a follow may be all right. It may be wise to put these patients on antiplatelet. So also is a diagnosed case of papillary fibrillostoma, where it actually is seen on the ventricular side of the aortic valve. You can see it very clearly here. You can see it clearly. This is the tumor mass. Okay. So fibrillostoma, they are seen in relation to valves, most often in relation to mitral valve. Mitral valve is mostly seen in and around the mitral valve. It may simulate a vegetation, so you have to be very careful. Unlike infective endocarditis vegetation, papillary fibrillostoma is seen on the downstream side of the valve. That's the one characteristic feature which has been projected or which has been stressed by the investigators, that if the small mass is due to papillary fibrillostoma, then it will be on the downstream side of the valve. Unlike in infective endocarditis, where it is seen on the upstream side of the valve. Mostly no symptoms and harmless. Usually they are without symptoms and may not give rise to any significant harm. So most of the times patient can be left alone. Rarely superimpose thrombus formation and embolization. That's the most important thing about which we are worried, which I had mentioned to you. In this patient, sometimes because of the platelet addition, activation and aggregation, sometimes these patients can develop thrombus on the tumor mass and can result in embolization. Lipoma or the RV of lipomas are also not a very uncommon tumor which can affect the heart. Can one of you tell me that how do you diagnose lipoma of the heart? Criteria? How will you diagnose lipoma of the heart?
Encapsulated and homogeneous structure, sir.
Very good. Usually it is a very homogeneous, smooth outer surface, and unlike in myxoma, it does not have any multiple projections or areas of calcification with areas of liquefaction, and there is no pedicle. All these features are features of lipoma. So let's look at a few lipomas. This is in the RV outflow. Here actually it has got a pedicle, but it was surgically removed, and finally it was found to be a lipoma. So it can obstruct the outflow region, give rise to murmurs, and of course, lipoma is a benign tumor, and it may not create much of a problem, but it may sometimes cause hemodynamic disturbance and needs surgical removal. Right atrial lipoma, somebody who presented with vague history of palpitation, not suggestive of tachyarrhythmias. He had some vague symptoms and he came for examination. And you can see it's a huge mass actually. If you look at the mass, you can see that it's a very huge mass. It's almost completely filling the right atrium. And you can see that it is mostly it is uniform. And unlike in myxoma, there is no projections on the surface of the tumor mass. Hence, embolic episodes are not common. What will be the clinical manifestation of a mass of this magnitude in the right atrium? Any one of you? Any one of you?
It will present like a RV inflow obstruction. So the JVP will be raised, and the patient may get pedal edema, ascites, hepatomegaly.
Okay, I agree with you. That patient mostly present with right heart failure, and since it is filling the right atrium, the jugular venous pressure will be significantly elevated. Right atrial pressure will be elevated.
Get diastolic murmur of the tricuspid valve.
Then, if the patient is having a patent foramen ovale, then there is a risk that these patients can develop right left shunt and may end up with cyanosis. And they may use that may make us completely miss the diagnosis. Echo can pick up the tumor mass, but clinically sometimes we may miss it because with the tumor in the ventricle. But right atrial tumors, especially right atrial myxoma, large ones, or a lipoma, sometimes can result in elevation of right atrial pressure. That can result in patent foramen ovale opening, and there can be a right left shunt. The patient may present with cyanosis even. So, whenever you are thinking of a patient with cirrhosis, you can always think of a differential diagnosis of a atrial mass, especially right atrial myxoma or lipoma. And the treatment, of course, is surgical removal. Any doubts? Somebody wants to ask? Okay, right. We'll go to right atrial masses. Right atrial masses are sometimes normal ones, like distribution valve, pacemaker, balloon or central line catheters, cysts, thrombus, tumors, and giant intraatrial septal aneurysm. That's somebody mentioned. Sometimes the giant intraatrial septal aneurysm sometimes may be mistaken for a mass. So when you look at lipomas, has been already told by Ronak, they are usually homogeneous, they are highly echogenic and refractory, and there are no infections on the surface of the tumor. And so embolic episodes are very uncommon with the lipomas. Rhabdomyomas, how do you diagnose rhabdomyomas? What age do you diagnose and what is the management? Anyone of you? How will you diagnose rhabdomyoma by echocardiographically?
Usually in children.
Yeah,
And
not in newborns, infants.
yes, sir.
Newborn or maybe in infancy. Yes.
Less than 2 years of age.
Family history also, and tuberous sclerosis may be present associated.
Beg your pardon?
Sir, family history may be present.
Yeah, yeah. What is the family history?
Sir, autosomal dominant.
Okay, right. Well, what is the abnormality that can you pick up in the mother of a child with rhabdomyoma?
Tuberous sclerosis.
Very good, tuberous sclerosis. The pigmentations and the projections on the face suggestive of tuberous sclerosis. Maybe in the mother, maybe a clue to the diagnosis of multiple rhabdomyoma or rhabdomyomas in a newborn baby. Okay, right? Yes. They are usually very often it can be multiple. And what is the special feature of rhabdomyoma?
They can regress.
They can regress and disappear over a period of time. They can regress and disappear, and so
Puberty again reappears.
rhabdomyoma. So, what are the conditions where you situations where you will treat rhabdomyoma? What are the situations where you will treat rhabdomyoma?
If they are causing mechanical obstruction,
Very good. If there is causing mechanical obstruction, too.
and if there is a chance of embolism.
Rhabdomyomas usually
No,
do not.
sir.
Arrhythmia.
Beg your pardon?
Arrhythmia patient.
Arrhythmias, arrhythmias. So there are two situations where you cannot leave a patient with rhabdomyoma. There is one arrhythmias, and second is outflow obstructions. The patient is having significant outflow obstruction and it is causing hemodynamic disturbance. Then you may have to go ahead and remove the tumor mass. Otherwise, most of the times leave it alone, and then mostly it will regress. Now, some of the anti-mitotic drugs have been tried, and some of them are found to be useful. So in patients with rhabdomyoma, sometimes certain drugs are useful. Very often there are multiple, and usually it can disappear over a period of time. As Saroj just pointed out, it can be multiple, and at the same time, over a period of time, it can totally regress or even disappear. An example of a patient, so you can see multiple tumors, both in the left ventricle, right ventricle, intraventricular septum, everywhere. You can see multiple tumors. Another case, again.
Also called Garland syndrome. Garland.
Garland?
So Garland syndrome, because multiple tumors like garlands. Garland syndrome.
Garland tumor. Okay. Yeah, yeah. Multiple ones. I have not heard that. So it can be called as Garland tumor.
Yes.
Okay. So the most important point is that if there is no arrhythmia, no mechanical obstruction, then you can leave the tumor mass, and over a period of time, usually regresses or completely disappear. Rhabdomyoma, it is usually in newborns, multiple, mostly spontaneous regression. That's the most important point you should remember. For a period of time, it can totally regress. So you have to reassure the parents. But if the mass is giving rise to a lot of arrhythmias and is giving rise to significant outflow obstruction, then you have to do something about that. Otherwise, most of the times these things will not be there, and the patient can be left alone, and they usually recover completely. So newborn, multiple, mostly spontaneous regression. The treatment is needed if there is outflow obstruction or malignant arrhythmias. I had one patient with rhabdomyoma, a person with arrhythmia, ventricular tachycardia, and then we had to do something about it. So whenever, I don't remember what I have advised them, but we thought of doing something so that the patient can have, patient does not have any recurrence of arrhythmia. So outflow obstruction or presence of malignant arrhythmias are two situations where you think of intervening in a patient with rhabdomyoma. Otherwise, just leave it over a period of 1 to 2 years or 2 to 3 years. It totally regresses and disappears. The cardiac tumors, primary tumors are malignant tumors, angiosarcoma, rhabdomyosarcoma, mesothelioma, fibrosarcoma, and malignant lymphoma. Sometimes cysts can also occur in the heart, and the important cysts are pericardial cysts, bronchogenic cysts, and blood cysts. Sarcoma, as I told you, whenever you are thinking of right ventricle, you should always think of the possibility of malignant tumors. And the RV outflow tumors are mostly malignant, and very rarely they are benign. So whenever you find a tumor in the RV outflow region, always think of the possibility of a malignant tumor. As an example of a patient with a tumor in the RV outflow region. Okay, I think we'll go to next case. 30-year-old male, exertional breath resistance 3 months, and ejection systolic in the third, and second right in the cost space. What do you find? It's another case of a right atrial RV outflow mass, and this was also turned out to be a malignant mass. So whenever you see a mass in the RV outflow region, there is every possibility that it could be malignant rather than non-malignant. While in other parts of the heart, actually the tumors are benign tumors. So the malignant tumors are most frequently seen in the right ventricle, and that too in the RV outflow region. So whenever you find a tumor mass in the RV outflow region, always think of possibility of malignancy. It's an example of a small boy who came to us when he was about 12 and had an systolic ejection systolic murmur in the pulmonary area. And when we did an echocardiogram, this is what we could get. So actually, it's a petangulated tumor. Does not have other features of myxoma like calcification and areas of liquefaction. That is not there, but still it is petangulated mobile. Always there's a tendency for us to diagnose myxoma, but this happened to be a sarcoma, and patient was given surgically removed, and it actually gave rise to RV outflow obstruction. And this is the mass which was removed, a large mass size of about 4 to 5 centimeters in length. And similarly, a large mass was removed, and it's done about 10 years ago. And the histopathology revealed actually it was a sarcoma, and is thought to be not very highly malignant, but malignant. And the patient is doing very well for the past 10 years, so he's fine. So we have left him alone at that level. Myxosarcoma, where the myxoma is turned malignant. Whole mass, it's a huge mass. This is huge mass here. It's occupying the whole of the RV outflow. So this is a case of malignant myxoma. The myxoma is malignant. So a few points about RV outflow tumors. RV outflow tumors are rare. Statistically, intracavitary RV outflow tumors are 70 to 140 times more likely to be malignant than benign. That's the most important point you should remember. If you are finding a patient has got an RV outflow mass, don't leave the patient alone, or don't give him too much time, because these are malignant tumors and it should be diagnosed as early as possible and should be treated effectively in the early part of the disease process. If it is a primary cardiac tumor, it is approximately 2 times more likely to be sarcoma than a myxoma. So a myxoma is can occur, but it's less likely compared to sarcoma, and it is almost 2 times more frequent, likely to be sarcoma rather than a myxoma. Of course, echocardiography can differentiate, and behavior pattern also can help to differentiate. Pericardial sarcoma. Pericardium is also an area where there can be malignant tumors. And here is the story of a 26-year-old male, no significant past history. In 2016, he had shortness of breath and was admitted to a nursing home, felt better with some symptomatic treatment. He was diagnosed to have antituberculous. He discharged on antituberculous treatment without his knowledge. He was given antituberculous treatment thinking that he has got tuberculosis, and but he quickly stopped all medications, and then he started having fever. This time he's admitted with significant dyspnea, atypical chest pain, and this echocardiogram. You can see that echo actually has pushed the heart to one side. This is the heart. This is the pericardial cavity on a side where there is a tumor mass. So you can see the mass here. It's also it is in the pericardial cavity, not into the cardiac chamber, and it was rapidly growing, and it was found to be a case of sarcoma. Okay, nothing special about the electrocardiogram. Histopathology shows spindle cell sarcoma. Pericardial tumors, they are rare. Malignant tumors, the tumors can be malignant. Incidence is 0.001 to 0.28% in autopsy series. Metabolic, they are actually mostly they are malignant tumors, and they can metastatize to the different parts of the body. Primary pericardial tumors, they are benign, mostly lipomas, fibromas, or hemangiomas, and they can be, if they are having hemodynamic disturbance, it can be surgically removed. Malignant tumors are sarcoma, that's the commonest, mesothelioma, lymphoma, and very high risk of metastasis. The secondary cardiac tumors, you should always think of a primary site. It's in good lungs, lymphoma, breast, leukemia, stomach, melanoma, liver, and colon. These are the sites from which the tumors can reach the heart. Most of these patients present as cardiac tamponade, where it is metastasized into the pericardium, and there is an acute pericardial effusion. Myocardial involvement in these tumors is extremely uncommon. Retinal cell sarcoma can spread through the IVC into the right atrium. Sometimes the cancer cells from the kidneys can reach the liver through IVC. One important point you should remember that what are the points by which you differentiate a cardiac tumor from a clot, thrombus? Any one of you? That's one important point you should remember. Whenever you see a mass, you should be able to differentiate whether it is a tumor mass or whether it is just a thrombus. Any one of you? How will you differentiate? There are a few points. Yes.
Sir, if it is mitral valve related thrombus, then it will be present in left atrium, attached to the one of the leaflet. If it is because of the LV dysfunction.
So in a patient with, you are saying that in a patient with mitral stenosis, there is a high risk of thrombus formation, and in that case, thrombus is usually formed in the left atrium. Very good. Yes.
Another point, if it is patient is have severe LV systolic dysfunction, then LV apical the location of the thrombus will be in LV apical. Most probably in LV apical. Patient may have embolic phenomena, like patient may have a stroke or maybe vascular occlusion because of the embolism.
See, there is a few points I have mentioned, a few points by which you should be able to differentiate the possibility of a thrombus from a tumor mass. One of the most important points is that for a thrombus to form, there should be a predisposing situation. So in presence of predisposing factors like stagnation of blood, that's the most important point. If there is a stagnation of blood, there's always a risk of a thrombus formation. Stagnation of blood, as can happen in left atrium in a mitral stenosis, right atrium in RV endomyocardial fibrosis, or in atrial fibrillation, there can be slowing of the circulation or stasis in both left atrium as well as right atrium. At LV apex, associated with echinacea or dyskinesia of that part of the myocardium. If the myocardium is infarcted and at the apical region, it is showing echinacea or even dyskinesia, then that can lead to stagnation of blood in that segment and can result in thrombus formation. So thrombus, most important point is the stagnation of blood. In presence of stagnation of blood, I have mentioned few situations like in a patient with mitral stenosis left atrium, in a patient with RV endomyocardial fibrosis right atrium, and in a patient with atrial fibrillation, either the left atrium or right atrium, and in a patient with myocardial infarction with echinacea or dyskinesia of that part of the myocardium, especially the apical myocardium, there is the risk of a thrombus formation. If you find a spontaneous echo contrast when you are doing a routine examination, that is also a situation where you strongly suspect the possibility of a thrombus formation. These patients are high risk candidates for thrombus formation. Predisposed sites of thrombus formation, like there are certain sites where thrombus formation is much more frequent than other sites. Maybe because these areas are become more stagnant and there is a high risk of developing thrombus formation. They include left atrial appendage, the sites of opening of the pulmonary veins, apex of the left ventricle, PFO, mechanoprosthetic valve, extension through the intravenous IVC, especially from the carcinoma of the kidney. So there are few specific features and few sites where the tumor mass is very uncommon is in the LV and RV outflow region where the thrombus is extremely uncommon. Thrombus cannot form there because the blood is always flowing through that region at a much greater velocity compared to other areas, and the chances of a thrombus formation is extremely low if the patient does not have any stagnation of blood in any one of the cardiac chambers. So in a patient with atrial fibrillation, both the atria can have stagnation of blood and can result in thrombus formation. The tumor mass is very rarely, the tumor can be pedunculated, but thrombus is very rarely pedunculated. It's mostly a fixed one. It is attached to the vessel wall or to the chamber wall, and pedungulation is not a feature of thrombus formation. Thrombus, they very unlikely that it is pedungulated. History of embolic episodes will be another point for you to suspect thrombus, and is rare in normal valves, and also very rare in the outflow regions where the blood is flowing very fast, and it's very uncommon to have a thrombus formation in regions where the blood is flowing very fast. Mostly it occurs in regions where there is stagnation of blood. Few examples of see, here is a huge thrombus in the left atrium. You can see very huge thrombus. See, huge thrombus. Actually, this patient, since there's a large mass, we request the surgeon to operate as quickly as possible so that we can prevent an embolic episode. And surgeon obliged, and the patient was taken up for surgery, and there was a large mass. Actually, left atrium was almost completely filled by the thrombus. Thrombus removed, revealing an ulcerated lesion of the left atrial endocardium just above the annulus at 3 o'clock position. Ulcer was debrided, and mitral replacement done with 27 RJM bileaflet valve. And this is the echo after the removal of the thrombus. You can see that the left atrium is free of thrombus now. Of course, there's a prosthetic material in the mitral position, but the thrombus has disappeared. Surgeon removed the thrombus. You can see this is a case of a ball valve thrombus. You can see multiple ball valve thrombi in a patient with mitral stenosis. And you can see inside the thrombus, we can see liquefaction. The thrombus can get liquefied. It's a tumor inside the not tumor. Multiple thrombi are seen in the left atrium. And this patient is a very high risk candidate to develop an embolic episode. Sometimes these patients remain asymptomatic, and with oral anticoagulation or with parenteral anticoagulation initially followed by oral anticoagulation, the tumor can completely get dissolved and can disappear. So, but of course, these patients have got a very high risk that they can develop embolic episodes into the brain and resulting in hemiplegia. So these patients, surgically, the thrombus should be removed as well as possible, and these patients may be put on long-term anticoagulation, especially if they have got atrial fibrillation. It is a left atrial appendage thrombus. You can see here there's a thrombus in the left atrial appendage and cerebral echo. What is this? What is this structure? Just above the left atrial appendage, what is the structure? Any one of you? Those who are doing transcerebral echo, that you can very clearly make out. This is actually the superior left superior pulmonary vein. This is the left superior pulmonary vein. This is the left atrial appendage. You can see a huge mass, tumor mass in the, thrombus in the left atrial appendage. So left atrial appendage is a very common site for thrombus formation. And another common site is that in and around the hypokinetic or akinetic area following myocardial infarction. And patients with dilated cardiomyopathy, where they have got a very poor ejection fraction, they have got also stagnant stability in the left ventricle, and that can result in thrombus formation. In the right atrium, one of the diseases which can cause thrombus formation in the right atrium is RV endomyocardial fibrosis. Sometimes you may be able to detect the thrombus by a transthoracic echo. Here, there is an example of a thrombus which we have detected, the transthoracic echo. You can see that thrombus mass is seen in the appendage. You can see it's being measured. The left atrial appendage can be seen. Do you know in which view do we see the left atrial appendage in the transthoracic echo examination? Any one of you?
Sir, in the short axis view,
Very good.
tilting slightly towards the left shoulder.
Very good.
At the aortic valve level when we are doing it.
Very good. At the short axis, we have the aortic valve level with slight tilt towards the left shoulder. We can bring out the appendage very well. Excellent. Yes. What is the other view?
Sir, apical 4-chamber view.
Very good.
Sir, tilting more anteriorly little.
Yes, very good. Take up the apical four chamber view and then tilt anteriorly so that the right atrium is better delineated and the left atrium is better delineated. You should be able to pick up the left atrial appendage also. So, left atrial appendage classically is picked up in the transesophageal echo, but you can sometimes pick up in the transthoracic echo also, especially in two views. One is the short axis view at the aortic valve level, and second is the apical four chamber view, where you can tilt the transducer slightly to the left, and you may be able to pick up the left atrial appendage. Here you can see actually a clot in left atrial appendage picked up in a transthoracic echo. But of course, when you do a transesophageal echo, you can find that it's a huge mass. It's a huge mass. You can also see there's a lot of the spontaneous echo contrast, which also tells us that there's a high risk of patient developing a thrombus. And this is a thrombus in the left atrial appendage. Right atrial thrombus. Right atrial thrombus, of course, occur in patients with endomyocardial fibrosis, but also you can see emboli sometimes which is dislodged from the deep veins, and it can go on to come to the right atrium. And these are patients who are going in for pulmonary embolism and infarction. It's only a large thrombus. It's a very huge thrombus. Whenever you find such a huge thrombus in the right atrium, you should always think of the possibility of RV endomyocardial fibrosis. So the mass is very huge. So you can see a huge mass here. This is a thrombus in the right atrium. You can see it here also. It's very easy to diagnose when you are in doubt whether it is a tumor mass or a clot. You can do an MRI. How will you differentiate by doing an MRI between a thrombus and a clot and a tumor mass? Any one of you? How will you differentiate a clot from a tumor mass by doing an MRI scanning? Any one of you? Yes, the clot is seen as a
Non-vascular.
non-vascular, and is also just like water, just like fluid. There is no opacification of the thrombus when you do an MRI, while the tumor mass is not like that. So tissue characterization is possible with MRI, and here is a patient under an MRI. You can see that there is a you can easily make out there is a huge filling defect. And this patient is having apical obliteration, so this is a case of RV endomyocardial fibrosis, large right atrium, and a huge thrombus. You can see thrombus, huge thrombus. You can see thrombus here also. So it's very clearly seen. If it's a tumor mass, it will be like a tissue. Here, this is a you can see it's a black, and this is suggestive of thrombus. So when you are in doubt whether it is really a thrombus or a tumor mass, you can always do a MRI also. But then the circumstance always will always help you to diagnose whether it is a thrombus or not. Thrombus usually occurs more in the left atrial appendage. That's a common site. Then it can occur in LV when the LV contraction is poor, as can occur in dilated cardiomyopathy, or it may be in a patient with myocardial infarction where the apical region may be completely akinetic and the blood may be stagnating there. So depending upon the circumstance, you should be able to diagnose whether it is a thrombus or and also location, thrombus or a tumor mass. LV thrombus, you might have seen plenty, where you can see the apical region which is not contracting well. The thrombus is formed here. Also you can see the thrombus. Recently, when there is a doubt about the thrombus formation, we can do a contrast echo, and contrast echo will definitely show the. So contrast echo is always useful to detect a small tumor, a small not tumor, small thrombus, which we are not sure about, or sometimes we might have even missed. And contrast echo of this nature can make out the filling defect, which is due to a thrombus. So thrombus can be diagnosed by here. You can see a thrombus here, and that is what is seen here. And the filling defect can be seen here also. It's not important to, we have done this in order to show to the students how a filling defect can be easily picked up in a contrast echo. Nothing special. You can see that you can see the filling defect here. See, at the apex there's a filling defect. There's a filling defect here. Here I am not sure about the filling defect, but you can definitely there is a, in these two regions there is a filling defect. That is because of the thrombus. So whenever you are in doubt whether there is a really a thrombus, if you want to confirm it, then one of the methods is to do a contrast echo. Vegetations. How do you diagnose vegetations? Any one of you? How do you diagnose vegetations? How they look like, how they are detected in the echocardiogram, and how will you diagnose vegetations? Any one of you? What are the features which will make you diagnose vegetations? Vegetations are structures which are attached mostly to the valve, or maybe at the regions where there is a defect like VSD. They are attached onto the upstream side of the valve. For example, in a patient with mitral regurgitation, it is seen on the left atrial side of the valve. In a patient with aortic regurgitation, it is seen on the RV side of the, LV side of the aortic valve. They have got independent mobility. That's the most important point you should always look for. Their mobility is independent of the valve to which they are attached. They have got independent mobility, and it can also get embolized. So, infective endocarditis vegetations, recognition by echocardiography has become one of the major criteria for the diagnosis of infective endocarditis. And when situations where the blood culture can remain negative and infective endocarditis vegetation detected by echocardiogram is considered as a major criteria for the diagnosis of infective endocarditis. The infective endocarditis vegetations can be quite variable. Here it is in a patient with a prosthetic valve, mitral prosthetic valve. The patient has got a vegetation here, which is on the left atrial side of the prosthetic valve, which will be missed in a transthoracic echo. Here you can clearly see it. So infective endocarditis vegetations, when you are looking for in a prosthetic valve, always try to do a transesophageal echo. It is only from a transesophageal echo that you can easily diagnose the infective endocarditis vegetations in a prosthetic valve. You can see a very huge vegetation here. So this is a very significantly very large vegetation. Here's an example of a patient with a right-sided vegetation. In a patient with a prosthetic valve, and not prosthetic valve, in a patient who has undergone a pacemaker implantation, the pacemaker lead actually going through the tricuspid valve resulted in tricuspid regurgitation, and an infection was settled, and that has given rise to a massive infective endocarditis involving the tricuspid valve, resulting in multiple emboli into the lung, giving rise to multiple pneumonia, multiple infarcts, and this all secondary to pacemaker lead which has resulted in across the tricuspid valve, which has resulted in tricuspid regurgitation and settling of the infective endocarditis vegetation. So sometimes vegetation can happen on the tricuspid valve. It is not common. Usually it is more common in drug abusers, but he's not a drug abuser. So sometimes it can happen in the tricuspid valve also, especially if the patient has got a pacemaker lead across the tricuspid valve. This is an example of a vegetation in a patient with VSD. The patient is having VSD. You can see a very huge vegetation. You can see something seen here. So actually in the pulmonary valve, you can see it here. It's projecting onto the RV outflow and into the pulmonary valve. This is the RV outflow. Okay. So this you can see there's a very huge mass here, which is actually falling into the RV outflow and also into the pulmonary outflow. The patient is having an RGVSD. So this is a infective endocarditis in a patient with VSD. Intracardiac mass vegetations mostly attached to valves or sites of abnormal jets, example VSD or PDA. It varies in size and shape. Size mostly varies from 2 millimeters to 15 millimeters. Rarely can be as long as 30 millimeters. When the valve size, when the vegetation size is more than 10 millimeters, it is thought that there is a high risk of embolization from the vegetations. So there is even a recommendation that vegetations which are more than 10 millimeters of mercury, those patients should undergo surgical valve replacement and remove the vegetation. Otherwise, they have got a risk of developing embolic episodes and may result in a stroke. It has got independent mobility. The mobility of the vegetations are independent of the valve mobility, valve leaflet mobility. Mostly associated with high velocity jets. It is usually in high velocity jet lesions that you get infective endocarditis, as can happen in mitral regurgitation, aortic regurgitation, aortic stenosis, ventricular septal defect, tetralogy of Fallot, and pulmonary stenosis. While conditions like mitral stenosis, where there is the relatively very low gradient, infective endocarditis is very uncommon. This is these are the few structures, normal structures, which can be seen in the different cardiac chambers and may be misinterpreted as a cardiac tumor, which include mostly I have marked them yellow. They are actually crystal terminals in the right atrium, Chiari network usage and valve remnants in the right atrium. Sometimes the moderator band in the right ventricle can be mistaken. Nodules of Arrantius. And does anyone know what is meant by nodules of Arrantius? And Lambel's excretions. Nodules of Arrantius. These are usually at the site of the central part of the commissures of the aortic cusp. Sometimes there can be small nodules, and these nodules are can be considered as normal, but rarely it can increase in size and may sometimes result in sometimes in aortic regurgitation, and sometimes it may mistake it for a vegetation. Similarly, Lambel's excrescents are also small projections from the center of the aortic valve into the. Sometimes it can happen on the ventricular side of the aortic valve, but they are usually at these two lesions are the center of the aorta, center of the valve where it comes together. All the three cusps come together. So when you find that there are some small projections at the center of the aortic valve, don't immediately diagnose infective endocarditis. It may be a normal or it may be a degenerative process, and maybe due to nodules of Arrantius or Lambel's excrescences. Mitral valve sometimes the redundant chordae or myxomatous mitral valve also sometimes may confuse you, and you may interpret that it may be a tumor mass or even sometimes even infective endocarditis vegetation. So you should be careful. Let me see whether it's an example of a case where we even got baffled because this patient came because she was to undergo a surgery and she came for a routine preoperative evaluation before undergoing a surgery. I think she was to undergo some abdominal surgery. Then what we found was that there is a mass here. When we found this mass, we were a bit worried whether it is a tumor mass in the right atrium. And so we were a bit worried about it, and so ultimately we decided the patient should undergo a MRI. And when an MRI was done, you can see that this is the mass which we were seeing. This is the one. This was actually a crista terminalis only. So sometimes a normal structure in a cardiac chamber, like crista terminalis in the right atrium, may be mistaken for a tumor mass, uh, uh, just like what I showed you now. We all thought that it could be a tumor, and but ultimately when a MRI was done, it was confirmed that it was not a tumor mass, it was only a crista terminalis. You can see this is the crista terminalis seen in the cardiac MRI, and it corresponded to the mass that we saw in the apical four-chamber view. And the patient got operated, and nothing was done to her because obviously it is a normal structure. You can see again, this is the region, this is the crista terminalis, which actually differentiates two parts of the right atrium. This is crista terminalis. Okay. East region valve is another structure which can be mistaken for a pathology. So you can see here there is east region valve here. You can see that it is moving inside the right atrium. You can see here east region valve. This should not be mistaken for a tumor mass. It is a normal variation. Sometimes it becomes slightly more prominent. That is why it is easily picked up in the echocardiogram. So the right atrium is full of structures which sometimes can mimic a tumor. One is the left atrial, the eustachian valve. Other is crista terminalis. These are two structures which can definitely confuse you. So be careful that sometimes a normal structure in the right atrium may mimic a tumor mass. I think we'll stop at this level. There are a few more things to be shown, which are mostly minor variations from the normal ones like calcified forced tendon, then a ruptured forced tendon. There are a few things which again normally see in the echocardiogram, but wrongly interpreted uh, 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 as a tumor mass, or it may be sometimes thrombus. All these wrong interpretations are possible. So you should be familiar with the structures which are sometimes seen normally and which may sometimes mimic or may confuse you as a tumor mass. I think we'll stop at that level. If you have got any doubts at the things which I have shown you and spoke to you, you can ask now. Otherwise, we'll stop at this level. Okay, if there are no doubts, intracardiac masses you must be able to pick up in the echocardiogram. And most important thing is to interpret it as whether it is a tumor mass or whether it is a thrombus, and also your ability to identify normal structures which may mimic a tumor mass. Okay, we'll stop at this level. Next week we'll have a case discussion, and if you have got a case, you please